Welcome, everyone. Thank you for attending CCHP's Medicaid and State Telehealth Policy webinar. Today's topic will be substance use disorders. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy. Before we begin, a few disclaimers and friendly reminders. Please note that any information provided in today's webinar is not to be considered legal advice. It is strictly for informational purposes. CCHP always recommends that you consult with your legal counsel in your organization if you are interested in a formal legal opinion. Also know if a product is mentioned or a company is mentioned, know that CCHP has no relevant financial interest, arrangement, or affiliation with such an organization. Today's webinar is being recorded and the slides presented here will be made available along with the recording a couple of days after the webinar on CCHP's website at cchpca.org. You may notice that closed captioning is available for today's webinar. So there is a button on your Zoom toolbar that you can click on if you wish to activate closed captioning. We also ask that attendees please refrain from political statements or advertising commercial products or services during this webinar. Additionally, if you have a question for our panelists, we ask that you utilize the Q&A function. The chat function should only be used for technical questions, such as if you are having issues with Zoom. Afterwards, this webinar, there will be an evaluation sent to you. So if you can fill that out, that would really help us out there. And then we will be moving on. So a bit of information about CCHP. We were established in 2009 as a telehealth organization for California policy underneath the Public Health Institute. An opportunity to become the federally designated National Telehealth Policy Resource Center became available through a grant from HRSA in 2012. CCHP applied for that. We got it, and we've been serving in that capacity ever since. We also work with a variety of funders and partners on the state and federal level on different connected health or telehealth projects. CCHP also acts as the National Administrator for the National Consortium of Telehealth Resource Centers, and we convene a group called the California Telehealth Policy Coalition, which is a group of over 150 statewide organizations, statewide and national organizations interested in advancing telehealth policy in the state of California. A little bit of background about the National Consortium of Telehealth Resource Centers. It is made up of the 14 telehealth resource centers who are funded underneath the same funding program under HRSA that CCHP is. There are two national centers. CCHP is one of them. We focus in on policy, and the other one focuses on technology, and they're based out of Alaska. There are 12 regional resource centers that serve particular states. So if you are located in the United States, you have a telehealth resource center that is specific to serving you. They are called the Regional Telehealth Resource Centers, and they are really sort of your front line for your telehealth questions. So if you have questions on program operations, on policy, on technology, you can reach out to your Telehealth Resource Center. When they have questions, the regionals, when they have questions on policy or technology that they typically can't answer, then they elevate it up to the nationals. A while back, the 14 Telehealth Resource Centers decided to pool a bit of our resources together to work on joint and collaborative projects. Hence, the National Consortium of Telehealth Resource Centers is formed. So you can reach out to any of us, and really you have the sort of like the 14 trying to help you on everything, because we do work very closely together and very collaboratively. So today's webinar is going to be focusing on substance use disorder and how telehealth is used to address that, and what are some of the policies that exist around it. We're going to look at this through a lens from like the federal level, from the state level for the state Medicaid program, and then on the local level with a program that's taking place in Philadelphia. This is the fourth of our summer series. There have been 3 previous webinars that have taken place. If you are interested in those webinars, they were on school-based and telehealth, licensure, and telehealth private payer laws. Those recordings are available on CCHP's website and our YouTube channel. We are very fortunate today with our great panelists as speakers. We will be hearing first from Dr. Robert Baillieu from SAMHSA. Next, we'll be hearing from Arkansas Medicaid, and we have lined up Patricia Gann, Jennifer Schuler, and Elizabeth Pittman. And last, we will be hearing from Philadelphia's Department of Public Health, Dr. Jeffrey Hahm. So we'll start off first with Dr. Baillieu, who serves as a physician and senior advisor at the Substance Abuse and Mental Health Services Administration, or SAMHSA, Center for Substance Abuse Treatment. He graduated with honors from the University of Sydney Medical School in Australia and completed residency training in family medicine at the University of Texas Health Science Center in San Antonio, where he was also chief resident. Prior to this, Dr. Baillieu lived in Australia, where he undertook training in adult internal medicine. He is a board-certified family physician, a fellow of the American Academy of Family Physicians, and a former Robert L. Phillips Jr. Health Policy Fellow at the American Academy of Family Physicians, Robert Graham Center, and the U.S. Health Resources and Services Administration Bureau of Primary Care. He holds degrees in medicine, public health, business, and modern languages, and he has experience in health systems research, policy analysis, community organizations, international business, management, public health, education, and medical practice. Dr. Baillieu is also a former assistant professor of clinical family medicine at Georgetown University, where he supervises residents and taught classes in policy, advocacy, statistics, and clinical medicine. Dr. Baillieu's research activities have focused on the primary care workforce, health IT, and the implementation of best practices at the community level. He has presented at national and international meetings and has published in international peer-reviewed journals. So I'll now turn it over to Dr. Baillieu.
Thank you so much, May. I hope you can hear me okay.
Perfectly fine.
Thank you, and thank you for your introduction. Perhaps if we could move to the next slide. Thank you. It bears mentioning, of course, that SAMHSA's mission is to reduce the impact of substance abuse and mental health illness on America's communities. And over the past 2 years, this mission could not have been realized without telehealth. The need to protect patients and providers, conserve protective equipment, and to maintain isolation was, and of course continues to be, in some respects, overcome through telehealth. Our experiences demonstrate that telehealth and virtual platforms, like the one we're meeting on today, are implementable, scalable, and effective. However, there is a way to go in promoting and integrating this important technological innovation. We must consider how it fits into the health system in the long run, while also overcoming inequitable access and issues related to disparity. If we could move to the next slide, please. As we all know, telehealth can connect clients and providers in multiple locations, such as at a home, private space, in a clinical setting, or another location in the community. Practitioners can use telehealth with a hybrid approach for increased flexibility. For example, a client can receive both in-person and telehealth visits throughout their treatment, depending on their needs and preferences. This model facilitates shared decision-making as the practitioner and client determine together the appropriateness of various telehealth modalities and identify when telehealth, in-person, or a hybrid approach will best meet the client's treatment goals. Appropriateness of telehealth may depend on several factors, including the nature and complexity of the intervention, and also the client's condition, the client's comfort with technology, and telehealth appointments, as well as also the ease and preferences of addressing in-person services or using technology. Beyond this, telehealth can address treatment gaps. For example, SAMHSA's NISTA survey showed that among adults aged 18 or older in 2019, 13 million of them had a serious mental illness. Of those, 6.2 million people perceived an unmet need for mental health services in the past year. Among adults aged 12 or older in 2019, over 20 million people reported experiencing a substance use disorder. 21 million people needed substance use treatment, but just 4.2 million people received any substance use treatment. Telehealth, in this respect, has the potential to address treatment gaps, making treatment services more accessible and convenient, improving health outcomes and reducing health disparities. Clients experiencing substance use disorders have traditionally been excluded from telehealth research, evaluating the efficacy of this intervention among people experiencing substance use disorders. However, over the last 2 years, we have seen an increasing amount of research addressing this gap, and we found that it is a tool that providers can use for all clients. Next slide, please. We appreciate that the COVID-19 public health emergency imparted significant impacts and that there were sharp increases in the number of adults reporting adverse mental health conditions and substance use disorders. This was particularly evident among racial and ethnic minorities, and of course contributed to overdose deaths. The public health emergency necessitated measures to promote distancing, and this saw a rise in telehealth. And telehealth, importantly, is a mode of service delivery that has been used in clinical settings for over 60 years and empirically studied for just over 20 years. Telehealth is not an intervention in itself, but rather a mode of delivering services. This mode of service delivery increases access to screening, assessment, treatment, recovery supports, crisis support, and medication management across diverse behavioral health and primary care settings. Practitioners can offer telehealth through synchronous and asynchronous methods. And in this way, as the public health emergency unfolded, it's become important in protecting the public and practitioners' health from being impacted by the virus. At the same time, we saw that access to care was essential. We saw increasing numbers of adults reporting adverse mental health or substance use disorders. Further to this, data related to racial and ethnic minority groups shows that they experienced higher rates of depression, substance use, and self-reported suicidal thoughts or ideation during the pandemic. We've also seen a substantial number of overdoses over the same time. Next slide, please. Thank you. Oh, here we go. Thank you. These strategies are so important as the United States is experiencing the most significant substance use and overdose epidemic it has ever faced. And this, of course, is exacerbated by COVID and driven by the proliferation of highly potent synthetic opioids such as fentanyl. The isolation, mental health concerns, and reduced access to resources experienced by so many during the COVID-19 pandemic has contributed to the sharp rise in overdose deaths. And certainly, provisional data from the CDC show that we have crossed the tragic milestone of a predicted 100,000 overdose deaths. This represents a nearly 29% increase compared to the same window of time last year. Next slide, please. A further concern is the co-involvement of other substances, particularly stimulants with opioids. Data from the CDC-funded SUDOR system collects information on unintentional and undetermined opioid-related overdose deaths from supported states. SUDOR's data has identified that over 3/4 of overdose deaths involve one or more substances, with any stimulant being the most frequent non-opioid involved. From other data, we know that fentanyl is often a contaminant in the drug supply. That leaves people who otherwise might not have experience with or may even be actively trying to avoid fentanyl vulnerable to unintentional exposure to it, and this often has devastating consequences. Importantly, the SUDOR's data find that few deaths involving the opioid agonist medications buprenorphine and methadone that treat opioid use disorder. If we could move on to the next slide, please. Thank you. Another great concern is the now very clear understanding that some groups have been disproportionately impacted by overdoses over the past several years, with exacerbations during the COVID period. The data on this slide from researchers at the CDC makes clear that Black people and American Indian and Alaska Native people are feeling the brunt of lives lost to stimulant and opioid co-involvement, even prior to COVID. A growing number of studies are confirming the overdose death rate among Black men surpassed that of white men in 2020, such that Black and American Indian Alaska Native men now are the demographic groups most likely to die from an overdose. This slide is also revealing, in terms of available data, publicly available data pertaining to race and rates of overdose, as well as other indices, have a significant lag. This complicates the timely response to evolving crises, as well as planning and policy. Next slide, please. We see here that there is disparate access to buprenorphine prescribers across the US. Indeed, research confirms that the majority of data waiver practitioners are found in urban areas. Telehealth has demonstrated potential in overcoming this disparity, and recent evidence demonstrates the positive impact of telehealth on buprenorphine prescribing. There are no reported differences in foundation of the Therapeutic Alliance when comparing in-person and telehealth buprenorphine visits, and there's also comparable safety and outcomes data. Next slide, please. Similarly, opioid treatment programs, which provide access to methadone, are limited mostly to urban and suburban areas. If we could move on to the next slide. Thank you. The telehealth flexibilities enacted during the pandemic facilitate buprenorphine prescribing, specifically by expanding access to care in OTPs and outpatient offices. In the primary care setting, telehealth can be used to provide access to buprenorphine. This is meaningful to those in rural and underserved areas, and it allows individuals to access care where they are. Next slide, please. This slide details a timeline of telehealth and associated activities. In April 2020, SAMHSA published a document that clarified the exemption from requirements for an in-person physical examination for new patients starting buprenorphine in an OTP, but this did not extend to methadone, of course. Then in June, the Centers for Medicare Services clarified allowances under Medicare for OTPs to use telehealth platforms for periodic patient assessments. What is apparent here are the different spheres of authority and influence that federal agencies exercise. When it comes to telehealth, SAMHSA's authority is really limited to OTPs, and we rely on interaction, negotiation, and conversations with many other federal departments. Next slide, please. What these flexibilities do are provide a leeway to create policies that support the use of telehealth. And to this end, SAMHSA has worked with operating divisions within HHS and beyond to expand access to buprenorphine through the practice guidelines, which remove the education and attestation requirements for those who wish to treat up to 30 patients with buprenorphine, as well as expanding the use of mobile medication units and in extending COVID flexibilities while decisions around making them permanent can be borne out. Many of these initiatives are enhanced through telehealth technology, and this allows the treating team, including counselors and allied health staff, to reach individuals subject to geographic disparity, while also positively altering paradigms of care. Indeed, telehealth's biggest impact has been to reduce the need to visit an OTB or practitioner each day. This supports employment and other important activities that are known to have a beneficial impact on recovery. Next slide, please. Research reveals that those with unstable access to broadband and internet face technology issues in using telehealth platforms. These individuals are potentially most in need of the increased access that telehealth offers, since they are minorities or based in rural areas or potentially elderly. This raises an important issue. While telehealth benefits so many, the silent minority, often those most in need of services, continue to face significant barriers to care. While federal agencies seek to overcome these barriers, this can take several years or even decades. The rollout of broadband technology, for example, doesn't happen overnight. If we can move to the next slide. Thank you. Beyond issues posed by the technology itself, there are challenges faced at the organizational level, provider level, and across the field. At the organizational level, there are significant costs associated with health IT and integration. These costs are often difficult to recuperate, particularly when reimbursement models do not keep up with emerging trends and paradigms of care. There are also workforce concerns, and while telehealth allows flexibility in providing care and can allow remote providers to see clients, this is only allowed when appropriate licensing platforms are in place. The effective use of technology also requires training that is not well covered in medical or professional schools, or even at the organizational level. Concerns about high acuity patients and their ability to be adequately assessed using telehealth can be a significant source of anxiety to practitioners as well. There are also challenges in planning. Federal agencies learned this early on as the need for reimbursement models became apparent. Care delivery systems and patient engagement significantly changed, and technology platforms required upgrading and maintenance. All this work required rapid adoption at the provider and client level. Many clients were distrustful of technology, and it took some time to demonstrate their effectiveness. If we can move to the next slide. Thank you. During the COVID-19 pandemic, SAMHSA took rapid action to facilitate the use of telehealth and drew upon DEA flexibilities and exceptions for controlled medications. The flexibilities described earlier further opportunities to provide care through virtual platforms, and SAMHSA made every effort to ensure that they could be adopted by OTPs and data waiver practitioners. Complementing this was extensive work in providing technical assistance, and our TA centers have developed several resources on telehealth implementation, and these include using technology-based therapeutic tools in behavioral health services, telepsychiatry in the era of COVID-19, telemedicine delivered buprenorphine treatment in the age of COVID-19, and of course, a Region 8 Behavioral Health Technology Summit. SAMHSA also produced an evidence-based guidebook, Telehealth for the Treatment of Serious Mental Illness and Substance Use Disorders, which addresses the use of telehealth across the continuum of care, as well as discussing practical implementation issues, while also reviewing the evidence base for specific treatment interventions. SAMHSA's grants also reflect this new paradigm of care. Through the Certified Community Behavioral Health Clinic grant, CCBHCs are encouraged to use telemedicine to expand access to services and alleviate workforce shortages. Block grants have also allowed states to advance telehealth opportunities to expand crisis services for hard-to-reach locations, especially rural and frontier areas, as well as expand technology options for callers, including the use of texting, telephone, and telehealth. Notably, states are not permitted to use the funds to purchase any items for consumers or clients. If we can move to the next slide. Thank you. The transition back to full-scale in-person services represents an opportunity for jurisdictions to fundamentally alter service delivery mechanisms to improve access and decrease stigma. In considering issues around population health, the cost of care, efficiency, enhancing the experience of care, addressing equity and stigma, telehealth can be a total system changer. We have really only started to appreciate its full potential. However, disparate access to technology, implementation costs, the regulatory environment, and demand for services act as significant barriers. These have the potential to adversely disrupt this important technology and its use in providing care to vulnerable populations. Next slide, please. I've covered a lot of information in this presentation, but there are 5 key points I'd like to make certain you leave with today. The most significant of these is that telehealth is here to stay, and its integration into care offers an opportunity to promote patient-centered approaches that allow individuals to better engage in treatment and in their health. And with that, we can transition to the next slide when possible. I'd like to say thank you for this opportunity, and also thank you for the work that you all do and for the interest you show. Thank you again.
Thank you, Rob. What an interesting and informative presentation. We've got a couple of questions for you from our audience, but I'm going to actually start off with my own question, because prior to the pandemic, in talking to at least a couple of providers, I'm not saying they're representative of the nation or something, they had talked about trying to get a Data 2000 waiver to be able to prescribe buprenorphine. Was there like a lot of uptake on that when that was made available to providers to do? Because I think, you know, coupled with telehealth, that would help expand access to services, but at least with the providers I spoke to, they either didn't seem interested or they thought the process was too difficult.
No, it's a really, really important point, and I thank you for making it, May. Certainly, the data waiver has been in effect for 20 years, and so during that time, we've been able to look at barriers to accepting that important waiver and prescribing buprenorphine. Certainly, a big element of not adopting this has been the perception that the education requirements are quite burdensome, and there's also concerns, natural concerns among providers about excessive oversight from the DEA. Mm-hmm. In part to alleviate those concerns, SAMHSA released the buprenorphine practice guidelines about 18 months ago, and these dispensed with the educational and also attestation requirements for those people who want to treat up to 30 patients with buprenorphine. We have seen a slight up intake of people getting waivered. It's interesting, when you look at who is getting waivered under the practice guidelines, it's mostly MDs and DOs who have an 8-hour training requirement, whereas NPs and all the other clinical nurse specialist areas require 24 hours of training. So one would think that they may take the accepted waivers slightly more readily. It's also a lot of emergency department physicians who are taking up the waiver. And so that potentially means that the emergency department is viewing itself more as a primary care stop for individuals with substance use disorders and in initiating treatment for these individuals in an ongoing manner. So that in itself has been interesting. But to answer your questions, there are significant perceived barriers to the data waiver. We've been trying to address them through different policy mechanisms, and actually we continue to actively study them. We recently released a survey to many data waiver providers to look at their prescribing patterns, to look at any issues they have around prescribing buprenorphine, because the other thing we know is that people will get the waiver, demonstrate some keenness in providing buprenorphine, but then drop off prescribing in the future. So that's another key area we need to look at, supporting individuals as they implement these treatment strategies and understanding why it is that they may drop off prescribing too. So these are all things we're looking at.
That's really interesting, especially the fact that there's the drop off, but also that you see more ER physicians who are going through the process to actually have that waiver there. Really interesting. We've got some questions from the audience members, and two of them are kind of related. I'll go with one first. So does the telehealth in this presentation mean only a video conferencing functionality, or it has other functionalities as well? If it does, what does it include? I guess they're asking if you are only talking about live video when you speak of telehealth in this context.
Yeah, no, good question. And certainly I can understand the context of the question too, because of our flexibility around buprenorphine, initially confusing, and then we allowed audio only. And so I didn't define telehealth too specifically, but I meant to define it as being any sort of platform that allowed communication, whether it be audio-visual, whether it be asynchronous, synchronous, or audio-only platforms of telemedicine. And certainly we've seen the adoption of all those platforms throughout the COVID-19 pandemic.
Okay. We've got a question from A.R. Williams saying, I may have just missed this. Has SAMHSA published formal guidance for tele-MOUD best practices?
In part, we published our evidence-based guidebook using telemedicine for the treatment of substance use disorders and serious mental health illness. And in that evidence-based guide, we elucidate best practices around the integration of telehealth in the treatment of people with substance use disorders. We do look at the evidence pertaining to the use of telehealth in these, but we don't have particular clinical guidance around this. And certainly tip 63, which is the fantastic tip that deals with medications for opioid use disorder, will require updating moving forward. We need to be cognizant of the integration of technology. So I thank you for that question and the important reminder that we at federal level remain very abreast of technology and its integration into practice.
All right, there are a ton of other questions for you, but we are going to move on to our next speaker. Dr. Baillieu will be back towards the end of the webinar when we bring back all of our panelists for more Q&A, but we are going to move on to a state Medicaid program and their approach to substance use disorders and how telehealth is woven into that. So as I pull up the PowerPoint once more, I like to invite our next speakers to please unmute and turn on their cameras. And as they are doing that, I will go ahead and run through their bios very quickly. So we have up first, I believe it will be Elizabeth Pittman, who graduated with a joint law degree and master's in public health in 2009. After spending a brief time in private practice, she worked as an attorney for child welfare and adult protective services with the Department of Human Services. Since 2013, she has spent her career working in policy development with both the Arkansas Department of Health and DHS. Elizabeth's passion and goal is to make policy that actually works for Arkansans. Next, we will hear from Jennifer Schuler, who is an acute care nurse practitioner with 11 years of APRN experience. She graduated from Arkansas State University in 2005 with a Bachelor of Science in Nursing. After working in critical care for 2 years, she enrolled in UAMS College of Nursing in 2007, seeking a Master's in Nursing Science. She graduated in December of 2010. She achieved national board certification as an acute care nurse practitioner in March of 2011. She is a member of Sigma Theta Tau Nursing Honor Society and the American Association of Nurse Practitioners, as well as the Arkansas Nurse Practitioner Association. With 19 years of clinical experience in various practice settings, Jennifer has worked as a nurse technician, licensed practice nurse, registered nurse, and advanced practice registered nurse in direct patient care. 2019, she transitioned to administration working at the Arkansas Department of Human Services in the Division of Aging, Adult and Behavioral Health Services with the treatment team under the Arkansas Drug Director, Kirk Lane. With her provider status and varied background, she helps to encourage other providers to become DEA waivered and provide office-based opioid treatment to better the lives of Arkansasians. Next, after Jennifer, we'll hear from Patricia Gann, who joined the Arkansas Department of Human Services in January of 2018 as an assistant director under Division of Aging, Adult, and Behavioral Health Services. She was promoted to deputy director in October 2019, assuming responsibility for the aging program as well behavioral health services. Prior to joining DHS, she held various leadership positions with behavioral health providers, as well as serving as the project director for providers' relations with value options. She received a BS from Cameron University in 1991 and her MS from the University of Central Arkansas in 1995. She loves spending time with her husband, Tim, and their amazing rescue dog. So I will now hand it over to the ladies from Arkansas. Thank you.
Thank you. I'm going to kick us off with just a broad overview of telemedicine policy in Arkansas, and then I will turn it over to Jen and Trish, who can walk you through more detailed things on how it relates to substance use and behavioral health. So we had some telemedicine in place in Arkansas prior to the public health emergency, but it was fairly limited. In that, I mean, it was available to pretty much every provider type within Arkansas Medicaid, but there were some requirements around it that we quickly lifted, thanks to some executive orders that were put in place by Governor Hutchinson. We lifted the requirement that services be provided not in the client's home. So prior to the public health emergency, a client would have to go to a physician's office or some other provider's office to actually access telemedicine services. We changed that with the public health emergency and allowed them to receive services in their home. We also allowed a provider to establish that provider-client relationship by accessing medical records, whereas before there had to be some sort of contact with the client prior to being able to establish that provider-client relationship and begin providing those services. And we allowed for audio-only technology, whereas before there did have to be a video component. And CMS and the federal government also at the same time allowed for some HIPAA-compliant flexibilities where the technology that was being used did not have to be HIPAA-compliant. And so you could use things like FaceTime and Zoom and things like that to give clients these services. In addition to that executive order that the governor issued specifically saying that we had to allow for those things, he also gave a broader authority to states to make changes to their policy without going through our formal public notice and comment period or legislative approval process. And so we were able to quickly do a lot of things around telemedicine that I'll go through on the next slide. Thank you. So using that executive order, we were able to expand the use of telemedicine in a lot of behavioral health services, including marital and family counseling, crisis intervention, behavioral health diagnostic services, substance abuse. We also were able to expand it in other areas, including some applied behavioral analysis therapy for individuals with autism, some therapies, some prosthetics and orthotics, as well as rural health clinics and federally qualified health centers, which also do provide mental health services. So we also were able to add some check-in services. So these types of providers can now perform check-in services. We allowed physicians and APRNs to do virtual check-ins for patients with chronic conditions so that they did not have to actually bring that patient into the office. They could do a telephone call or a video chat with them and bill it separately. We also allowed some providers of early intervention day treatment, adult developmental day treatment, which is individuals with developmental delays or disabilities, to do some well checks when they close their facilities down. They were able to then go in and do well checks. And similar for behavioral health clients who receive intensive day services and maybe were not able to go to the facility to receive those services. And Trish may be able to talk about this a little bit more, but we did allow them to do well checks as well. So after we were put in those initial flexibilities, we came in and decided we wanted it to last through the entire public health emergency. So we came in and did this COVID response manual, putting in place throughout the public health emergency, several of those things. I know it says on here through December 31st, that's actually through the end of this year or the end of the public health emergency, whichever ends first. So we now have all of these things in place through policy to get us through the end of the public health emergency. And this can be found on our website if you're interested in seeing what our policies look like. And then we also were able to go in and put things in place permanently, thanks to some legislative action during the 2021 general session. And they passed 2 acts that made permanent those flexibilities that the governor put in place through that executive order. So clients now do not have to go to a physician's office or another provider's office. We will always be able to allow them to receive services in their home. Audio technology can be used where it's appropriate. So if the service itself does have a visual component, you cannot use audio technology, but we are allowing that where it is appropriate, which would include a lot of the services that the other 2 ladies will talk about today. And then we do allow that provider-client relationship to continue to be established as long as the provider who is giving the telemedicine services can access the records that they need to provide that service. And that can be done through an electronic health record. And we continue to look at ways to use telemedicine and technology to better expand services, including the use of technology and crisis response services for behavioral health clients. We're looking at how to allow first responders to actually use some technology, iPads, things of that nature, to get in touch with behavioral health clinicians to stabilize in times of crisis. And also looking at enabling technology for those individuals that we serve through home and community-based settings, including those individuals served through our 1915I home and community-based state plan for individuals with behavioral health diagnoses. And so we actually provide quite a few home and community-based services to those clients, supportive housing, supportive employment, and several other things. And we are looking at how to allow enabling technology in those spaces so that they can have more freedom. And that would include things like using distance monitoring, so that a provider could actually monitor clients who needed some additional assistance due to their functional deficits, but we would not have to be in their home with them all of the time. And so that allows for more freedom for those clients, which is ultimately the goal of those home and community-based waivers. And that is a very brief overview of what we have been able to do using telemedicine policies, and thanks in large part to some of the flexibilities put in place by the CMS, by our governor, and by our legislature. So thank you very much. And I will turn it over to Jen now.
Hi, good afternoon, everyone. Thank you for having me. Thank you, Elizabeth and Dr. Baillieu and May. I just want to very quickly go through a set of slides that you all will receive later, because I would rather talk to you about telehealth in this presentation is generalized for our MAT program. And the reason I'm using this presentation is we actually created, implemented, and started education on this program prior to the public health emergency. And in conversations with May for planning, she felt that this was very interesting and that we should share it with all of you. So this is just a standard definition of what is MAT. When we went through and wrote this policy, we talked to providers that were offering these services. We went through the TIP 63 with a fine-tooth comb, all 3 of its revisions that year. We looked at what is best practice and how can we create a safe place for our clients to get treatment in a primary care office. And the reason I'm so driven to do this work is in my last practice role, I worked in a rural ER and personally lost 9 young men to opioid and multi-drug overdoses in a 10-month period in a rural setting. So this is very hard for me. So if you'll move on to the next slide. Arkansas Medicaid made some big changes, and some of this is a little old, but at the time this was written, standard Arkansas Medicaid clients could only have 12 visits a year without additional paperwork. There were allowances and ways to expand that. However, that was what most of the clients understood. And after their 12 visits, they would just stay home, in my practice experience. It also allowed them to exceed the limits for laboratory and x-ray services and exceed the number of prescription, most of the clients called them slots, that they were allowed to get per month. They also were not charged a copay. Next slide, please. So the way we structured the program is we made sure that every client who unlocked those additional allowances had a diagnosis of MOUD, and we tied all of the software coding and billing through that ICD code. We did write out a structure for the providers to follow to ensure that people who had access to buprenorphine were able to also have access to counseling services, urine drug screens as needed, prescriptions, et cetera, without barriers. Our biggest goal was to figure out every barrier that would keep someone from seeking help and to pull it down and to do it in a safe way that was sustainable. Next slide, please. So this is the process for our providers. So far we've had over 120 providers complete this process. I get a report every week from Elizabeth's fantastic statistics team, but they have submitted, of the over 500 providers we have in the state, which we had 86 when I started, and we've had some really wonderful grant projects and programs that have assisted with that. We've got over 500 waivered providers, and we have over 120 that have enrolled in this program. And I get questions about it every day. We usually add anywhere from 0 to 5 per week. Next slide, please. So a lot of people, when I started talking about this, were like, well, you have to be a psychiatrist to offer this service, or especially in the APRN world, you have to be a psychiatric APRN to offer this service. So we made sure that we wrote in here everyone who could offer MAT. Next slide, please. So then we wanted to make sure that there wasn't abuse. So there has been, because I worked in pain management, there have been some off-label and mostly inappropriate use of some of the MAT drugs in the past. And we wanted to make sure that our program had the structures to support recovery rather than just another prescription being written. If you'll go for the next slide, please. We also wanted to make sure that they could have their appropriate drug and lab screenings and have all their consent forms. Next slide. And then we directed the providers to the TIP 63 and to that treatment contract so that everyone knew coming in to this program with whatever provider offered it, what was expected. And we ensured, and Trish was very, very strict on this, and rightfully so, that this is not just a prescription program, that we wanted our clients to get treatment and quality treatment. And we wanted to ensure that we made this as accessible as possible through the use of telehealth and through a bundle payment. Next slide. So this was just how things were supposed to go. For the first year, there were requirements to make sure that we're actually doing the program, that the person is being seen at least once a month. It does say office visit, but that did allow telehealth. Drug testing is appropriate, and that they were offered counseling services, or it was documented what was going on with their counseling. Next slide. And then we said, you know, some people use MAT for years, sometimes the rest of their life. So we wanted to make it a little bit more sustainable for them. So we moved everything to quarterly if they had been meeting their markers and goals. Next slide. And then we put in our audits, you know, because we have to make sure that we are spending our money appropriately. And that's just all laid out through here. Next slide. And then we very clearly said they were expected to adhere to the SAMHSA guidelines because, as Dr. Baillieu mentioned, they do change and they are being updated. And we wanted to make sure that our providers were using the most updated and evidence-based sources rather than being tied to something specifically written in a manual that may be outdated, that is a long process to change. Next slide. So this is just the sections, and you will get these slides if you'd like to pull any of our manuals, but this has all the different information about how to bill. So one of the FQHCs had a model where they had the patient come in, meet with a provider and meet with a counselor all in a shared visit in 30 minutes and assess how things were going. And sometimes the patient would ask for an individual session and they would just walk over with the counselor and do that individual session, or they would set up that. And that kept down on people having to come into the office as often or having to come in on separate days. So one of the questions I got from providers was you can only see one provider a day. So they can't come in and see the APRN or MD and then see the counselor. So that kind of tore down that barrier for them, that they could see more than one provider in one day, and they could bill at a bundled rate if they were seen by two providers in the same visit. Next slide. This is just codes. You guys are welcome to look any of this up. Next slide. And then it's got about the rates and about how we bundled in the services, but we did drug and lab screening were separate. Next slide. And then this is our codes and our reimbursement. This is kind of where I want to sit for most of the rest of my time. As you can see, we set up codes for telemed that paid the exact same as an office visit. So this was to increase accessibility, especially for our rural patients. It's kind of embarrassing, the map Dr. Baillieu showed. It looked really ugly in Arkansas. We had a lot of dark blue where it said we didn't have many service providers. And I really want to update that because I know we have over 500 now. And that was probably based on our number of 86 back in 2017, 2018. And these are great rates. And I wanted to make sure that I pointed that out to you. And this is for that shared visit. Next slide. And then this is just more about our billing rules. Next slide. And that is it. And I'll be happy to take questions. And I'm very pleased to turn this over to Trish Gann. She's been an excellent mentor and has taught me a lot about the counseling world and how to make sure that our patients are cared for. Thank you, Trish.
Thank you. It is so good to be here today. And I'm going to say I don't have any slides today because I know that Director Pittman as well as Jennifer Schuler have done an excellent job of giving you our policies and giving you our processes that we use. So I kind of wanted to talk a little bit more about just generalities around how we got to where we are today. Like Jennifer said, we actually started talking about a lot of this and putting telehealth into our system long before COVID came along. So as Director Pittman said, a lot of our telehealth policies that we have now were informed by COVID and by the public health emergency, but Arkansas was already moving forward with behavioral health transformation. And part of behavioral health transformation was to include telehealth as a place of service for many of our outpatient behavioral health services. The other part of behavioral health transformation that was probably more important is that Arkansas for years had only allowed for the provision of substance use disorder services through our contracts and grants. It was not a service that we paid for in terms of counseling services under any outpatient program. We paid for individuals who had mental health disorders, but when we were looking at substance use disorders, that was primarily funded through our contracts. In 2018, we went through behavioral health transformation, and as part of that, we added in codes for individual therapy, family therapy, the things that Director Pittman had talked about. We added those into our manuals so that we began an outpatient behavioral health to pay for substance use services for individuals as well as for Medicaid services. So that began this process. And then as we moved into COVID, we already had the groundwork to be able to move forward and add telehealth as a means of providing these services, both the telehealth for audio, visual, as well as phone telehealth through some legislation that came along later. So we're really happy that we began that process in 2018. It really positioned us in a good place to be able to move forward when we were discussing MAT and to give options for individuals to get substance use services who had Medicaid and to have that paid for by their Medicaid rather than having to get those services through contracts or grants. That to me is kind of how I wanted to talk about wrapping all of this up. And we all are very happy to answer any questions you have.
Thank you, ladies, for providing that great overview of what you're doing in Arkansas. Jennifer, you alluded to this when you were talking that we had some discussions before this webinar took place. And you had mentioned that while you guys do have these open policies with telehealth that do encourage the use of it, there hasn't been as much uptake as you thought there would be. Even though the policies, and as you said, the rates were really good, that the providers, either the providers haven't been offering it or have the patients not been as interested in using telehealth, or is it a combination of the two?
Well, I think it's a combination of the two along with the public health emergency. So as everyone knows, addiction, overdose went rampant when everyone was sent into isolation. So most of the providers I was talking to were just completely overwhelmed by trying to keep up with COVID to try to integrate this into their system. However, hospital systems were really great at integrating because they were able to recruit those ER providers and have them become waivered and then get them enrolled into the Medicaid program to be paid. Now, as far as clients, I think most of our clients were just unaware that they had that ability for access. If they were getting services in another way, like they were getting mental health services or they were already getting counseling services at one of our contracted or funded providers, they were more likely to understand that they could access MAT at those CCBH sites. I always get the letters wrong, but the integrated mental health and help me, Trish, the integrated mental health and physical health sites were really great at integrating and putting this in. And then the grant that I work on is a mental health and substance abuse 24/7 hotline that has all telehealth providers. And they had some struggles with trying to figure out how to offer MAT through that because none of them had any experience in substance abuse. So they were able to make some strategic partnerships and try to get clients referred over to more experienced providers that were comfortable offering the service.
Yeah, and I would guess for your clients, they probably ran into the same trouble a lot of people did. And what Dr. Baillieu mentioned in his presentation is maybe they had like equipment or smartphone technology issues in accessing that, or maybe even broadband and accessing that. That probably also limited like the use of telehealth, even though, as again, you guys do have some pretty flexible or broad policies there that allow for it. We do have some questions for you, ladies. Let's see, there was one here. Medicare, it's from Atif Marota. Medicare has moved to monthly bundle payment codes for OUD treatment, G2086 and G2087. Has Arkansas considered echoing that change?
So I could be wrong, but I believe that those are for methadone treatment. I'm just going to speak as if they're for methadone treatment. So we did discuss having that weekly bundle because all 6 of our OTPs in the state are currently cash only, and really struggled with first accepting Medicare because they didn't understand the difference between straight Medicare and a Medicare replacement plan. So they were getting paid on those G codes from the straight Medicare plan, but the Medicare replacement plans, they were not getting the reimbursement and they felt like they were losing money rapidly. They have asked for that. However, from my understanding from Elizabeth's team, and I'm glad she just turned her mute off, that it would have required a lot more time. And we wanted to get this out. And to do that, we had to go with a fee-for-service model, even though we had considered it.
That's absolutely right, Jen. What she just said is correct. We were trying to get something in place relatively quickly to make sure we were in compliance with CMS's requirements. We are currently working with, I think it's the Pew Foundation, on some substance use measures that we can move forward in Arkansas, and they are helping us with some bundled payment research. So we're still continuing to examine whether a bundle is appropriate in that space and how to move it forward. But we just really did not have enough time to really get a value for that bundle and to get that policy in place.
We have another question. It's from somebody who wishes to remain anonymous. Do nurse practitioners need to have collaborative agreement with a physician to participate in the Arkansas MAT program?
Currently, yes. So we have some pretty specific laws around Schedule II prescribing in Arkansas, and Arkansas nurse practitioners are very excited that we are moving towards full practice authority. However, there's a lot of questions around if full practice authority will include Schedule II prescribing. And specifically buprenorphine prescribing. And from what I understand, that's still being debated and discussed and created in the rules for full practice authority. If you ask the National Nurse Practitioner Association, they will say that we are not getting full practice authority because of the Schedule II issue. However, it was the best compromise we could come to with our physician partners in the legislature. So we are moving in that direction, but currently it does require a collaborative practice agreement. And I do have physicians that have offered to collaborate for no cost with our Arkansas nurse practitioners. And I create those linkages and send them sample collaborative practice agreements. And my favorite person to have them collaborate with teaches a class every Friday through Project Echo model. And his only requirement for collaboration is that you attend his Friday noon class as much as possible to be able to ask questions and kind of staff the cases that need staffed on that Friday at noon.
Yeah, so just as a reminder for some of our audience members, there is only so much that a Medicaid program can do. They would either need to wait for like approval from the feds, from CMS, or they may need to wait for their state legislature to allow them to move forward on certain policies. So thank you, ladies. If you can just come back like later on towards the end of the program, we're going to move on to our next speaker now. Thank you for our audience members. I know you all have a lot of questions, but we do have one more speaker left who needs to present here. So as he comes on, I am going to pull up his PowerPoint here. And our next speaker is Dr. Jeffrey Hahm. He is the former medical director at the Division of Substance Use Prevention and Harm Reduction in the Philadelphia Department of Public Health. In this role, Dr. Hahm helped lead citywide efforts to reduce the individual and collective harms from drug use via prevention, treatment, and harm reduction initiatives. One key focus area was expansion of buprenorphine, including a waiver requirement in Philadelphia's large health systems, buprenorphine provision in the city's jail, and the recent launch of a peer-centered telebuprenorphine line in partnership with the University of Pennsylvania. So I'll now turn it over to Dr. Hahm.
Great, thank you very much, May, and good afternoon to everyone. I am very grateful to be part of this webinar today and to both learn from colleagues and to share a little bit about our perspective in Philadelphia. My hope is actually to focus a little bit more on the implementation side of things, of what's been sort of possible as a result of the changes that have occurred in terms of the policy in Pennsylvania. As is sort of shown on the slide here, I just want to sort of set the stage a little bit about our overall response, but Philadelphia is grappling with a very high death rate related to substance use and overdose, especially with regards to opioids. Certainly this is a national public health crisis, but just this slide puts into perspective a little bit of how we've been approaching our work in Philadelphia. As you can see, we are at the very top here. We have the highest overdose death rate of the top 10 largest cities in the country. And a lot of this is unfortunately sort of being driven by opioids and increasingly polysubstance use. There are a lot of factors that conspire to Philadelphia having such a high overdose death rate. Some of them are socioeconomic. It is the poorest large city in the country. But then a lot of them also have to do with the drugs themselves. And that's what we'll talk about in the next couple of slides. I'll say a few words about our overall response and then really certainly focus on our partnership with colleagues at the University of Pennsylvania. But to set the stage a little bit here, Philadelphia has had high rates of opioid prescribing regionally. And I sort of start with this slide because about 80% of all of our overdose fatalities in Philadelphia currently involve an opioid. As Dr. Baillieu mentioned earlier, a lot of it is being driven by fentanyl. But this traces back, our today's opioid crisis. We do trace back to the high rates of opioid prescribing that have happened specifically in Philadelphia. And so this is a map of the Mid-Atlantic broken up by counties, and areas in dark blue are those areas with high amounts of opioid prescribing as measured by MME per person. And then areas sort of in the lime green, light yellow reflect areas with lower amounts of prescribing. And as you can see, Philadelphia in the middle of that red square there has had pretty high amounts of prescribing historically compared to even sort of neighboring jurisdictions such as New York, Baltimore, and DC. And as you can really sort of see on that legend at the bottom of the map, the distribution is not linear. The amount of prescribing that's happened in Philadelphia over the years has been about roughly 20-fold that of some of our neighboring large cities. Next slide, please. And then we certainly understand the connection that for some individuals, not everyone, but some individuals who misuse prescription opioids may make this transition to heroin. And in Philadelphia, that is a particularly grave problem where the heroin has historically, again, been sort of very pure and cheap. These are now data from the DEA and shows the purity of heroin among all the different sort of cities that are listed there on the x-axis. And on the very left there is Philadelphia. These data are a little bit old, but back in 2015, the purity of heroin in Philadelphia was among the purest in the country, with samples averaging about 75 to 77% pure. That same year, if you sort of look at the height of the red columns and the right-hand y-axis, you can sort of see that the cost of heroin that year was also among the cheapest in the country. So you have this sort of perfect storm that's brewing with a number of individuals who are exposed to opioids via prescription opioids, and then having very sort of pure and cheap fentanyl. The purity of heroin is certainly going down in Philadelphia, and this is due to the fact that sort of what you see on the slide here is that the purity is going down because it's being replaced by fentanyl, and this is certainly happening not just in Philadelphia, but across much of the country. So these are data from the Medical Examiner's Office, which is part of the Philadelphia Department of Public Health, and this shows the presence of different drugs at the time of death among someone who has had a fatal overdose. And as you can see in that line in orange there, showing this very steep rise beginning in 2015, 2016, is just the number of individuals who die with fentanyl in their toxicology. This graph sort of shows two things to me, one of which is just the prevalence of fentanyl in our drug supply and in our decedents, but also that the polysubstance use is also very common. You can also sort of see that the second highest, the number of overdose who died of cocaine in their system was the second highest, followed by benzodiazepines, followed by pharmaceutical or prescription opioids, followed by methamphetamine, and then then heroin. And we do know that individuals do die with multiple drugs in their system, making this crisis certainly one of polysubstance use. But given how much fentanyl we also sort of do see, we do want to make sure that individuals who have a history of OUD do have access to treatment. Next slide, please. The blueprint for how the city and all of our partners respond to this is sort of outlined by the mayor's task force. This was a group of 23 individuals from partners across the entire city, not just the city's administration, who came together to articulate 18 recommendations in these 5 strategic areas for how the city, again, and our partners could respond to this crisis. I won't go into all 18 of those recommendations, but if you are interested, the URL is at the bottom. I'll touch upon a couple of them and then just sort of really just jump into our focus on treatment and again, our work around telemedicine. Next slide, please. I do want to sort of mention that the mayor's task force did make the recommendation of thinking from a primary prevention point of view, and to think how can we reduce people's initial exposure to prescription opioids. So on the left is a picture of April. She's an individual who is in recovery with OUD. She was one of the faces of our campaign just to raise awareness around the risks associated with pharmaceutical opioids. The middle picture on the right are some of the educational materials that we have developed and distributed as a health department in order to support colleagues in healthcare settings to prescribe opioids more judiciously. Next slide, please. On the other end of the spectrum is thinking about harm reduction. How can we support support individuals who may not be ready or may not be interested in treatment at that time, and to make sure they do not have a fatal overdose before they have a chance to enter treatment. And one of the things that has happened in Philadelphia, which is a little bit unique, is that we recognize the importance of making naloxone as available as possible to all members of the public. And so we actually have a city law that actually requires pharmacies to carry naloxone. The state in Pennsylvania already has a standing order for it, but we recognize that there were not all pharmacies were stocking naloxone. And so all pharmacies in Philadelphia are required to stock the medication and to dispense a sign similar to the one you see on the right that's visible from the point of sale. Next slide, please. But even pharmacy access for naloxone may not be low barrier enough. And so one of the things that we have recently done in Philadelphia, and this is relevant to sort of how I talk about our telemedicine work, is creating even lower barrier access to naloxone. Pharmacies are an important distributor and distribution point of naloxone, but we recognize that there are still limitations. It may be because of stigma. It may be because someone doesn't live near a pharmacy. It may be because the copay may be too high. And so we do have these Naloxone Towers, the first of which was installed outside of a West Philadelphia library. It's available 24/7. These are like Amazon lockers where you engage with that screen on the interface on the front there, and then a locker pops open and provides you naloxone. It also has a 911 feature in the event of an emergency. So I've talked about a little bit our prevention and now our harm reduction efforts. And I do want to now sort of focus on our work to expand access to treatment. These are data from the Pennsylvania DHS, which administers our Medicaid program in Pennsylvania. And it shows a number of Philadelphia Medicaid beneficiaries who are receiving one of the 3 FDA-approved medications for the treatment of OUD. The height of each column in orange is the number of individuals who receive treatment with methadone. The portion of the column in blue are individuals who are receiving treatment with buprenorphine. And then that small portion at the top of each of those columns on the right there are the number of individuals, Medicaid beneficiaries, who are being treated treated with extended release naltrexone. Our data really are only great beginning in 2015, but you can sort of see since then that 85% of our growth in treatment with MOUD is with buprenorphine. It has been very difficult for us to expand access to methadone as much as we may like to, owing to a number of the challenges that exist with prescribing methadone for the treatment of OUD. So this just shows a little bit of our trajectory. And then the picture on the right is Kenny. He was the face of one of our buprenorphine campaigns that we had that was running with the tagline, "I'm living proof that bup works," which we modeled after a successful campaign that was done in New York City. Next slide. Here are just some initiatives that we have run in Philadelphia. We have, in order to sort of increase access to buprenorphine, we have a mentorship program where we connect newly waivered prescribers with experienced outpatient prescribers of buprenorphine. We have an academic detailing program that has visited both prescribers and pharmacists to educate them about the importance of prescribing and dispensing buprenorphine. As May mentioned earlier on in my introduction, we've expanded buprenorphine in the city's jail. And then we do have a DA who also supported buprenorphine access by decriminalizing its possession, which is something that was modeled and followed after what was done in Vermont. Next slide, please. We also work with all of our health systems the four largest health systems in Philadelphia to really make it actually a requirement that that the primary care providers specifically all be waivered, which was an important step that we made just in terms of trying to normalize this, trying to make sure that providers are able to offer this life-saving medication. Next slide, please. And so here's sort of what we've seen as a result of a number of these efforts. We've seen the number of providers, of ex-waivered providers has increased over the years, going from around 350 back in 2018 all the way up to now 1,300 in the early first quarter of this year. Despite that, next slide, please. Despite the increase, the number of patients has actually sort of plateaued. So we haven't seen that sort of linear growth that we had seen in the number of ex-waiver providers that was on the previous slide, leaving us really sort of thinking about, more needs to be done and what more could we do within the city of Philadelphia. Next slide, please. So this is sort of what I was coming to, is that while treatment capacity has increased, low barrier options are needed. And it's the same sort of thing I was sort of saying about naloxone, is that, we have all these pharmacy access points, but low barrier options are still needed. And so this is a map of Philadelphia. It's broken up by zip code and areas. This is sort of a number of fatal overdoses by incident location. And we have overdoses that were happening across the entire city. And so I appreciated the map that Dr. Baillieu sort of shared early on around sort of these deserts, these areas where there are very few, if any, buprenorphine prescribers. But I will say too, that as much as it is very true, I think in rural settings, that they do exist in urban settings as well. And that sort of led us to really think through how can we expand access and really sort of take advantage of some of the policies that were changed at the state level and make telemedicine a reality in a city like Philadelphia. So next slide, please. So with that, I'm going to share a couple of slides about what has happened in Philadelphia. And I do specifically want to acknowledge the hard work and the contributions of the team over at Penn Medicine, whose slides I have borrowed here with their permission, and who are also on the line here. I really do want to give so much credit to Nicole O'Donnell, who is a leader in this program and really runs a lot of the telemedicine work out of Penn Medicine, and Dr. Jean Marie Perrone, who really were champions in getting this started. But their story really sort of begins in the early months of COVID, when telehealth was used to fill gaps that were created by these disruptions in care that have now been discussed in the previous presentations, and by the significant decarceration that we were seeing in Philadelphia. And the picture on the right is of Nicole, who again is also on this call. So thank you for joining us, Nicole. Next slide. In early 2021, then, what also sort of happened, not we weren't sort of anticipating certainly this to happen, was the closure of several high-volume buprenorphine clinics. And this then sort of also prompted the use of telemedicine and what Penn Medicine had already sort of established to rapidly reconnect patients to care. And this was a partnership that was done in collaboration with Penn Medicine, also with the Pennsylvania Department of Health, as well as my department, which was the Philadelphia Department of Public Health. And I mentioned that too, because I think that this partnership has been a really valuable one. It's allowed us to really think through how can we utilize the strengths of a large health system with the connections and the resources of a state department of health and a local health department to really ensure that the reach of a program of a telemedicine program is as broad and as wide as it can be. Next slide, please. And so there were a lot of lessons that were learned, I think, especially by my colleagues from Penn Medicine, but I think also by the health department as well. It's just the importance of providing same-day access to medication treatment, and then how important sort of this close touch from experienced navigators really can be. Next slide. And so here is sort of the outcome. Here is our warm line itself that is now operational in Philadelphia. Again, it is being led by colleagues over at Penn Medicine, but here are some of the sort of the key features that have been, again, made possible by the policy and the regulatory changes that have happened in Pennsylvania. So callers are connected to substance use navigators right off the bat. And I think this is a really important thing to lead with and to mention, is that callers, whether they are patients or providers, they are reaching someone who is knowledgeable, who is compassionate, who is thoughtful, and who is really familiar with the landscape and how referrals can be made if and when they are needed and requested. The Care Line, the Care Connect Warm Line provides same-day access to buprenorphine. We recognize that one of the challenges in Philadelphia, despite the wealth of providers that we do have, is that still same-day access can be hard to come by. It may still be days or weeks, and you may lose that window, certainly, to engage someone who is ready to begin treatment. The program fills gaps between patient call and community MOUD appointments, ensures patients do not lose access to medications. And so one of the things that the Warm Line staff have really learned is that this service is needed for individuals who are newly trying to connect with treatment, but for also people who have been in treatment but may lose their treatment for whatever reason. Maybe it's because of a change of insurance, maybe because their own situation has changed. And providing scripts to help get them back on track and connect them to their long-term provider again is key. We do know that those gaps in care can be devastating. Tailored referrals to longitudinal treatment, whether that's specialty behavioral health or primary care based. The program also provides a wealth of harm reduction information and resources. And again, this is a line that both patients and providers can call for help. One of the things that we have since learned by this growth of ex-waiver providers is that there is still this discomfort, this hesitation of how individuals, how they can potentially prescribe buprenorphine or connect their patients to other resources if need be. So much of this, this talk of my presentation has sort of obviously been around buprenorphine, but recognizing how common, polysubstance use is in the city and across the country, these navigators are also familiar with how to connect individuals to methadone, if that's what it is, or with other sort of use disorders. And so I think it's another sort of important thing to mention, and we want to be able to provide this resource both for patients and providers. Next slide, please. So the Warm Line sort of began with a very sort of soft rollout, trying to sort of build up its capacity to understand what the need would be, to work through some of the kinks. So all of the data that you now see on this slide is from sort of a period of time before any sort of advertisement was done. This was all sort of through word of mouth. But there's been about 184 total encounters as of the time that these data were pulled. 86 were for non-prescription encounters, meaning that it may have been for harm reduction resources, just general questions, may have been for referrals to methadone, but those sort of what's sort of encompassed in the non-prescription encounters, 98 buprenorphine encounters, and then a total of 125 prescriptions that have been written. Next slide, please. Here are some of the demographics of the first 98 callers that have called into Penn Medicine's Care Connect Warm Line. I won't sort of go through all of these line by line, but I think I would sort of just mention here that the number of callers who have called in, it's diverse. I think it is meeting a need. I think that it's still a goal of the line and of the health department to ensure that we develop our programs through a lens of equity, and that is something that is central to the work that we and our partners do in Philadelphia. But I think those are some things that are just sort of exemplified here. And then again, the fact that 79% of callers have had Medicaid coverage, about 13% have other or are uninsured. And then a lot of the housing status is at the bottom too, recognizing that folks may need this sort of service coming from a range of housing sort of status. Next slide, please. And here are some of the outcomes. And again, I really do want to give credit to my colleagues who are on the line here, but that it has been successful. They have learned a lot of lessons. I think that as we try to think about scaling this up, these numbers will, I think the the evidence that is being generated is really important. And this has been done certainly in other parts of the country. I know there's certainly been some publications on this, but really the one thing that I sort of think about is just how to, local data is so important, especially as we sort of think about engaging local policymakers. And so here are some of the outcomes that have been reported so far for those first patients who have called in. 100% of patients triaged to telehealth encounter receive a buprenorphine prescription. 94% of those patients pick up that initial prescription within 7 days. And then you can sort of see down the line of what happens a little bit longer out. But 49% have an active buprenorphine prescription at day 30. And that's still pending for recent patients. But that is successful. I think we're always striving to see what we can do to increase that engagement and that connection. And these data are all sort of used. We get this from the PDMP, just in case folks are wondering sort of where those data come from. But these are encouraging data, especially when we, again, sort of as you see on this slide now, the before advertisement has really sort of gone out before this article was published in WHYY in Philadelphia. So going beyond word of mouth, I think the expectation and the hope is certainly that the utilization of this line will indeed increase. Next slide. So this is my penultimate slide here. Just some observations and conclusions. It's just that one, telemedicine, for substance use disorder care is something that I view as important in my role in the Philadelphia Department of Public Health as an important component of our city's effort to ensure low barrier access to evidence-based treatment for all city residents. I think supporting an experienced, innovative, and thoughtful partner organization was key to the successful launch of this warm line. The impact of substance use navigators and certified recovery specialists or peers really, I don't think, can be overstated. A partnership between the health system and the health department, I think, has opened doors to new referrals, both into and from the warm line. One of the goals that the warm line strives for is to really ensure that people are connected to a resource that is in their area or is amenable to them. And so I think by utilizing this partnership and this collaboration, we've been able to sort of think through how can we connect individuals to the warm line, both into it and then from it. And then I think the challenges are some of those that have come up earlier on this in this webinar, but just the need to expand and enshrine telemedicine policy. It was great to sort of hear some things that have happened in Arkansas now, as well as sort of thinking about sustainability. I think that there really is important lessons that we need to learn about telemedicine broadly in the wake of the pandemic, but really, especially with thinking about this population and providing really great care for individuals with substance use disorders. Next slide. So with that, thank you. Again, I appreciate this time to sort of be part of this panel to learn from, again, my colleagues who have sort of already presented. So thank you very much, May. I'm happy to answer any questions.
Dr. Hahm, that was fascinating, especially some of like the initial work that Philadelphia did, even before the use of telehealth came in, just sort of like very comprehensive work there, like buprenorphine in the jails and like having primary care providers make sure that they have the waiver in place where they can prescribe. So really just fascinating hearing that transition, that whole arc. A couple of questions for you. For this particular, do we call it a pilot, a project that you're doing that's being done with UPenn? You said like there was that, really concerted effort to make sure that people had access to buprenorphine and that they had same day access. In the prescribing of that, for that particular aspect of that program, have you been relying on the COVID waivers for prescribing a controlled substance, which means, because we're in the public health emergency, it is a little bit easier to use telehealth to prescribe. Is that been sort of the basis of how you've been able to do that with this project? And if so, what is going to happen once the public health emergency is declared over? Because at this point, there's no indication that the federal government would extend that allowance once the public health emergency is declared over, unlike some of the other telehealth waivers that have taken place.
Yes, great question, May. Thank you for bringing that up. And that is something that has been a challenge and a concern in Philadelphia, but also across the entire state of Pennsylvania, is there was an initial concern that this was going to end even sooner than the federal emergency. And so there's been sort of a lot of discussion with our state partners of thinking, how can we essentially ensure that this does remain? To what extent can that be done with the current sort of setup, with how this is being done both in Philadelphia County as well as in Pittsburgh and sort of Allegheny County, which is in sort of the western part of the state. I think that the more local evidence that we're able to sort of show of the true importance of this, again, I think that the two areas in which this is most developed are urban settings in Pennsylvania, but I think we certainly recognize the impact that this could also have really across the entire Commonwealth. And more recently, there have been, I think, sort of positive discussions around other sort of substance use issues in the state of Pennsylvania with some of the legislators that give me cautious optimism that there is an understanding of the need to ensure that access to these medications is as low barrier as absolutely possible, and even can we take some things even further, perhaps, to ensure that it is available not only to city residents, but really across the entire Commonwealth.
Mm-hmm. And thank you for that. I may have missed this during your presentation, but who is funding this pilot? Is it based on Medicaid reimbursement for the University of Pennsylvania, or is it like grant funded? I mean, where is the funding coming from actually doing this terrific program?
No, thank you, ma'am. Sorry, I did not mention that. So you did not miss anything there. The initial pilot has been done with using grant funding. And so and I think one of the things that we have certainly learned and thought about is to what extent some of these services can be billable. And since then, Penn Medicine has moved in that direction, and this has added sort of some elements of that. The challenge that we're having, that one of the challenges that I see in this whole sphere that is related to telemedicine, but also beyond that, is sort of the ability for health systems or clinics to really ensure that peer navigation and substance use navigators are a reimbursable service. In Pennsylvania, they are currently not under the Medicaid program. And I think that we're missing a huge opportunity to, one, ensure sustainability, and also two, just to recognize the huge importance that this workforce, that this population really can provide, this expertise. To me, that is something that I really would like to see states across the country really move to ensure that that contribution from peer navigation, from peers, is really recognized.
Good point there. I noticed you mentioned how important they played in this project, and I totally agree with you, like not even just for substance use disorder, but for like other conditions. Sometimes when you do have those navigators helping you, it really does make a difference in the treatment and also the consistency of the treatment that a patient receives and their sort of willingness to adhere to whatever treatment program they've been given. Let me just check really quickly, because I have not been monitoring the Q&A function too closely here, just to see if there is a specific question to you. I'm not seeing anything at the moment here. So I'm going to invite back all of our panelists right now just to take a couple of questions that we have in the Q&A function here. And one of them, I'm kind of combining a couple of questions here because I've seen it crop up a lot. And that is a question about audio only. Pre-pandemic, wasn't really considered telehealth or underneath the umbrella of telehealth, but now it's changed because of the pandemic. It's now considered, at least statutorily or in policy in some jurisdictions, as a part of telehealth. But there is also a concern of like, is it as good as like an in-person or a live video? So this has been more of a general question on like, what is your thought or what is your approach to audio only and providing services? I mean, Dr. Hahm, I don't know how much that plays into like the pilot you're talking about. In Arkansas, I think you did mention that you were allowing some audio only, and Dr. Baillieu, I think you said like that sort of was encompassed in sort of your general sort of overview of definition of telehealth, but could you get a little bit more specific on like, is there limitations that you think that, or that your policy has in there, like Medicaid, is there limitations on like use of audio only, or any other guidance that you can give to folks on like how audio only should be used? So I put that out there for all of you. Dr. Baillieu, why don't we start off with you?
Thank you, May. It's a really good question, and certainly a high source of confusion. The audio-only telehealth is allowed with buprenorphine, and certainly it's a patient-centered decision. So the practitioner should take care to assess whether audio only or audio visual or even an in-person visit is the most appropriate way to help the individual. We always encourage the patient-centered approach, and that's standard across the practice of medicine and treatment of substance use disorders. Certainly from a sort of regulation perspective, we look at the evidence when thinking about extending these flexibilities, when thinking about making them permanent. And certainly the evidence supports the use of different types of telehealth for different circumstances. And so certainly at SAMHSA, we're looking to extend these flexibilities beyond the COVID-19 pandemic and then to make them permanent moving forward. But that takes a lot of work from a regulatory perspective, which is why we have to do the temporary measure, then the permanent measure. So with that, I yield the floor.
Arkansas Medicaid?
Sure, so you are correct. We did expand to allow for audio only telemedicine within Arkansas Medicaid. We do follow scope of practice rules for different practitioners. So if their scope of practice requires certain things for them to provide that service, then they would have to follow that with us. And there are certain services that we really do feel like they need a face-to-face component, and this isn't involved in substance abuse. But for example, we allow for telemedicine to do a wheelchair evaluation so that a wheelchair can be developed for an individual that needs one. That would need to be done using a video component because you would have to be able to see the client to be able to really do that. And so we do have instances where we do require it. And with that being said, Trish, is there anything you'd like to add to that for behavioral health services specifically?
Thanks, Melissa. Thanks, Elizabeth. You know, it's been a long day and a long week, so I really apologize for that. I do think that there are some services, for instance, Arkansas has made the choice not to allow group therapy via telemed, except for, a certain age group of individuals. So we've looked at what is clinically appropriate. We've discussed safety issues and things like that. So we just want to make sure that we're providing the best services possible to individuals and that we're ensuring that good clinical practice as well as safety, that we have safety in place for our individuals within the state.
Dr. Hahm, are you using audio only in this particular pilot, or has it been all live video?
It has been, my understanding is that it's been both.
Okay. So we have a question from Michael Mather. Providers struggle and often do not understand how technology can enable making it easy for patients to connect. For example, we are trying to connect patients from home via their TV. Have you considered separating the reimbursement and paying directly to technology companies? This will reduce the complexity for the providers to deploy, maintain, and update technology that do not fully understand but are forced to manage and implement it. Oh, I think that's probably that's a deeper policy discussion than I think maybe our folks here will be able to dive into. I'm kind of thinking, and panelists, correct me if I'm wrong, this is talking about other departments that need to be involved and maybe some legislators also talking about it as well too. But I don't know if you have any thoughts on this question. But because as all of us have pointed out during this time, equipment is like a particular issue, like access to equipment has been a particular issue as well as broadband. And we know like some state governments and the federal government definitely have tried to address the broadband issue to an extent, but equipment has been like a little less sort of like focused in on. Like Dr. Hahm, for your project, you said they use both audio and video, so it's probably dependent on like what the person calling in to the hotline, what they have access to, whether it's they just have access to like a phone line, or if they have like a smartphone, they can maybe do video too. Do they have the option of picking that, or are they directed in some way?
It depends a little bit on the actual settings. Sometimes there is just a phone line that will connect to the sort of call center that ultimately helps manage this. But if they are in a setting, like if they're inpatient or something, we're trying to set them up for a script as they're leaving, telemedicine, as a video may also be an option there.
Okay, we're going to take one last question. It's, I think they leave Tanya Harris. I think I kind of know the answer to this, but I just want to double check. So does chatting or messaging cover is that covered under your definition of audio only? I'm kind of guessing probably no for a lot of you. That's like its own sort of separate category. Yeah, I'm seeing like a lot of nodding heads like, no, that's audio only is audio only, and chatting and text messaging is something else. But that is an interesting question, because I know in talking with some providers here in California during the pandemic, they were saying that the chat and text function has been incredibly helpful, especially when they've been dealing with a younger population, just because they have been so used to the chat and text function. Now, this is not for the prescribing side of things, but more for like the therapy interaction and the mental behavioral health services there as well. So I don't know, do any of you have any thoughts on the use of texting, at least for providing that type of therapy? From the policies that Arkansas went over, I don't believe you guys cover that underneath Medicaid, but Dr. Baillieu or Dr. Hahm, any thoughts on texting and, chatting?
I can't comment on the policy implications because the designation of telehealth is up to a different department, but certainly patient-centered approaches are really important, and safety is important too. And so establishing safety through mechanisms that allow the practitioner to work with the individual to establish a treatment program is essential. And then texting and chatting may form an adjunct to that. There are sort of modern delivery platforms that include that, and it does help alleviate some of the workforce issues as well, whereby people with different qualifications can engage in the chat function per se. So there's some workforce issues there. There's certainly considerations for patient safety. There's considerations for patient engagement too. So these technology aspects are exciting, and they pose real challenges from a regulatory perspective in terms of ensuring that there is safety, ensuring that the quality of care is maintained, and making sure that all the sort of payment mechanisms are in place as well.
So for those out in our audience there, what I think I also heard in a bit of that is, if you are a funder, perhaps fund some research into this so you can provide more evidence and data and information to people who are in policy positions that can maybe enact some change, but they need some data and evidence on that around that first before they go down that route. So we are at time here. I just want to thank everyone again. This was a terrific webinar. I learned so much. It was great to hear like the whole sort of like arc of that all of you brought to like the story, both on the federal level and the state Medicaid program, and for the Philadelphia program, what was going on in Philadelphia. I want to thank you again for making this such a great success here for our last webinar of our summer series. Thank you again to Dr. Baillieu, Dr. Hahm, to Elizabeth Pittman, Patricia Gann, and Jennifer Schuler. We really appreciate you taking time out of your incredibly busy schedules on a Friday. Patricia, I'm there with you. It's Friday. It's been a long week. So thank you everyone for taking the time, for bringing your knowledge and your insight into this, and like sharing this educational experience with everyone here today. Again, I just want to remind folks, if you are interested in our past webinar or recording of this webinar and the PowerPoints, they are available on the CCHP website. This webinar, give us a couple of days for us to get it up and the PowerPoint. So that will probably just check in next week and it'll be there. You will also receive an evaluation form when we close out the webinar. Please fill that out. That really helps us out in planning future webinars and subject matters. Also, if you are interested in any type of information, particularly like state-specific information around telehealth policy, you can go to the CCHP website. Again, I just wanted to ask you to fill out the evaluation. Thank you so much to our great speakers. Thank you everyone for attending. Have a great day. Stay safe, everyone. Bye-bye.